Welcome to the Cafe Culture podcast, a season of discussions on culture, politics, philosophy and science.
This event was recorded on the 17th of June 2013 when Professor Gary Green discussed can we or should we read the mind?
Thank you. Can you hear me? Yeah, fine. Thanks very much for coming. I'm going to start. One of the things I want to do here tonight is say a few things which hopefully will generate a debate. So I'm going to try and be provocative, and I'm going to do it in three different sections so that we can put this all in context. We're going to start with some quotations. So some things from the newspapers. So in The Guardian, headline, scary or sensational, a machine that can look into the mind. Again from The Guardian, a brain scan that can read people's intentions. And then a call for ethical debate over the possible use of new technology. Show it's not just a Guardian thing. In The Telegraph, mind reading by MRI scan raises mental privacy issues. And for those of you who were here a few weeks ago, Raymond Tallis was speaking probably about another issue, but in The Observer on the 2nd of June published an article, think brain scans can reveal our innermost thoughts, think again. And I'll send that round and you can see what he had to say about it. So it sounds as though people are getting very hot under the collar about the things I'm going to talk about. But it turns out it's not new. People getting worked up about this. This is the front page of a magazine. It's called New Biology, and it talks about the functions of the central nervous system and the anatomical basis of sensory experience. And in that article, it talks about exactly what I'm talking about today. But this is from 1946, so it's not a new concept. So what are we going to do? Well, I'm going to divide this into three different bits. I'm going to talk a little bit about what we do in York and put it in a clinical context about what we're trying to do. I'm then going to talk about where it's really going next and how what I'm going to start talking about is used and where it may be about to go. And in particular, I'm going to talk about a very big ethical debate about dealing with people who are in vegetative state, people who are unconscious. And then at the end, I'm going to talk about the really scary things, the things that people are getting worked up about predicting human activity, brain activity, things like detecting deception, detecting who are the criminals. So what I do, I work in, as you heard, a brain imaging centre. What we're about is there's a whole gang of people there, and what we're interested in is the brain, how it achieves its very remarkable normal behaviour of things like perception, cognition, at different aspects of thinking, and we're also interested in how it goes wrong. And let's start off by giving you an example of that. I know there are quite a few people here who are interested, for example, in epilepsy, but people might not know the magnitude of the problem we face with dealing with epilepsy. There are 300,000 people in this country with epilepsy. About a third of them, 100,000, are well controlled on standard drugs. 100,000 are fairly poorly controlled on standard drugs. But there are 100,000 people with epilepsy who are not controlled by modern drugs. And that gives them and society quite a very difficult problem to manage. So what happens to these individuals? Well, they might be, about 10% of them will be considered for surgery to try and find out where the epilepsy is coming from, and then they can have the highly invasive surgery to try and cut out that bit of part. So how do you find out where it's going on? How do you find out which parts can you cut out? And how do you leave behind what are called the eloquent parts of the brain, the parts of brain you don't want to cut out because you don't want to interfere with other aspects of that person's normal function. They're already handicapped by having quite severe epilepsy, you don't then want to cut out the part of the brain that deals with language or is dealing with memory. So how do you do it? Until 1996, the way you had to do this, to find out which side of the brain language was on, you injected an anaesthetic into the carotid artery. And it just would turn off one side of the brain, and then you did it in the other carotid artery and turned off the other side of the brain. So these people are perfectly conscious. It's called the WADA test, and it's a very invasive procedure. 1 in 100 people, when they have this procedure, have a stroke. 1 in 1,000 die, and this is a very high risk. And then, even then, when you found out the language area is over here, and I'm going to leave the language area alone, I'm now going to go in and do the surgery, I need to find out where it's going on. So people, what they used to do is take off a flap of skin, take off a flap of bone, and then take off the coverings of the brain and put electrodes onto the surface of the brain whilst the person was awake, was conscious, and then try and find out where this activity was coming from in the brain. Again, a very highly invasive procedure with a lot of morbidity. So, but now we have access to technology that allows you to find out where functions go on in the brain and find out where epilepsy is coming from in a non-invasive way. And these are the sets of technology that you have here in Newcastle. It's found in many, many hospitals and many centres around the world. And one of the problems with this technology is it can be used to look at, or one of the issues about it, it can be used to look at all sorts of functions and processes within the brain. So what are the technologies? Well, one of them is MRI, magnetic resonance imaging. It's a standard tool in a hospital. It's a very big magnet. What it allows you to do is find out where magnetism from atoms are coming from and map that throughout the body. And it's an extremely powerful technique. It gives you very good spatial resolution. We can work out, look at anywhere in the body with less than a millimeter resolution. And because it can look at structure, especially of soft tissues, which is hard to do with X-rays, there are about 40 million scans done a year in the world to be able to look at the structure of the body. But what it can't only just look at structure, it can look at function. And I'll be talking a bit about that later. And that's one of the issues it gives us, one of the problems it will give us. Another device is called an MEG machine. This is a device that actually can work out which bits of brain are active and when they're active. It has remarkable, very high temporal resolution. And you can say when the brain is active, and you can do that less than 1,000th of a second resolution. You can also see where it is actually going on. So these two technologies allow us to say where things are in the brain and when things are happening. So let's give you some obvious examples. Well, of course, clinically, the scanners are used to look at structure. They're used to look at where tumours are. They can tell us where abnormal development of the cortex of the brain. If anybody wants to know about anatomy, I was told I couldn't use PowerPoint or anything, but I have brought a prop. So if you want to know about different bits of the brain when we'll get to the questions, I've got a prop. But the foldings of the brain, we can actually look at whether that's developed normally and whether that is the cause of epilepsy. And of course, with the MEG device now, we don't have to take off these layers of the skull. We can actually use this device to actually tell us where in the brain an epileptic event has started, how it's spread across the brain and give rise to the phenomena that you see in particular types of epilepsy. But here we go. We're now going to talk about one of the first ethical dilemmas this brings us to. Not only can you use it to see disease now, you can also use these machines to predict who's going to get disease. So just take one example. In the Mayo Clinic, they're interested in Alzheimer's disease, a particular type of dementia. Now, if you have or get Alzheimer's, only about 25% of people can you predict that from genetics. The rest, 75%, you can't predict who's going to get it. Well, most of us are going to get it if you live long enough, but particularly early onset dementia, very, very hard to predict who's going to get it and what you do with it. But they showed, by using an MRI scanner, that by looking at the structure of the brain, that one particular area shrinks, and it is a very good predictor of those who are going to get dementia. And this is a particular bit of brain right underneath, under here. It's a bit of brain that's shaped a little bit like a seahorse, and it's called the hippocampus. And that area is related to a particular aspect of memory. And if that area shrinks, it's highly likely you're going to get dementia, way before you actually do. Let's take another event, another type of thing where you can look at structure. If you look at the brain over time in adolescence, in a certain group of adolescents, you can actually predict who's going to get a psychosis. And these are the siblings in families where there are more than one person who've had a particular type of psychosis. And certain areas shrink. They are to do with the auditory areas, which are related to how you hear voices in the world, and some frontal areas to do with behaviour. And these areas, when they do start shrinking, we know give rise to auditory hallucinations and the behavioural problems in schizophrenia. But 96% accuracy, you can tell in these high-risk families who's going to get psychosis before they do it. So the first ethical dilemma, do you treat that before they actually have the psychosis, before they have the brain changes? And I hope that's something we can return to. So the next bit about what these scanners can be used for is that they can be used to map where functions are. So you can use them non-invasively. You just put your head in a device that looks like a bit like a hairdryer. And if you go in that, you can find out where language is going on in the brain. It's not just one area, it's a whole network of areas. You can find out where the encoding and recall of memories occur in the short term or in the long term. And I know you've had talks here about narrative and things. You can actually work out which parts of the brain are involved in that. What parts of the brain are involved in vision and what parts of the brain are involved in action, making decisions and actually carrying out a movement to do that. So let me give you two examples of how to do that, because that's going to be relevant later. So when you're looking at the world now, as you are, light comes from different parts of the visual world and it goes into your eye and it hits different parts of the retina. And so light coming from over there at the moment is hitting the retina on my left eye on the most lateral bit, and in my right eye it's hitting the bit near the nose. And that information goes to the cortex, goes up here to the back of the brain, round back here. And on that back part of the brain you retain a map of the visual world. So this bit of brain over here is dealing with everything that comes from this part of the world, and it's all mapped out. And this part of the brain here is dealing with that part of the visual world, and it's all mapped out. So there is a map of the visual world, and then different areas deal with what you're processing in those different parts of the world. There are parts of the brain that deal with looking at faces, how you deal with looking at objects, and how you look at places, like how you analyse what's going on in this room as a place. So there are different levels of processing you do. But one of the interesting things is that you retain this concept of a map. And so one of the things that you can actually do is show lots of images and record the brain activity that comes from these areas. And one of the things you can actually then do is turn this back on its head and take the brain activity and say, what was the image that created that brain activity? So from the brain, you can read the brain. Notice I haven't used the word mind yet, even though that's in the title, and that's going to be a debate. You can read the brain and say that person was looking at this scene here. And this has been used to the extent that you can actually present large numbers of images to someone, record all the brain activity, then allow them to go to sleep and dream, and then afterwards you can say your visual dreams, your visual imagery was this sequence of events. And not only that, they've shown that watching a movie that they could reconstruct, not to terribly high resolution, but they could actually work out what you saw in the movie. So reading the brain is able to reconstruct from that activity. Because of this map, you're able to work out what it was. And not only are you able to work out what it was, you're able to work out when it happened. You can see when in the brain you actually there was enough activity, and this is going to be a debate, I hope, you can say from the brain activity when the data allows you to say it was a face or it was an object. And of course, the debate is about, well, is that the same as conscious awareness? Okay, so we can do that for vision, we can do it for action. You can actually get people to have imagine they're going to make a movement. So like hitting a hammer, playing tennis, exploring a room. And you can see which parts of the brain are active for each of these different types of action. And this is already used in brain-computer interfaces to be able to read out information from the brain and control a wheelchair, for example, control a speech device. But it's used in another way, and this is another very big ethical dilemma. It's now starting to be used in a clinical context. Now, I'm sure you probably are aware that quite a few people have head injuries every day of the week. There are all sorts of reasons. They can be alcohol-induced, they could be traffic accidents. There are a whole number of reasons why people have head injuries. And in Newcastle, there probably are 6 or more, 10 or more people who will come in and be admitted for a mild head injury every day, probably alcohol related. And most of those will go home, they won't be kept in, and there is a thing called the silent epidemic that's going on. What will happen is a number of them, probably about 10%, slowly but sure will have a cognitive decline over 6 months to a year. They will have problems with attention, problems with memory. Mild cognitive impairment is not rare. Some will go on to a much more serious condition, and they will be in what is called a vegetative state. And this is quite a problem because people in a vegetative state, I'll define it in a minute, have to be either in intensive care or high dependency units. They need a lot of care, and those resources are very few and far between. They're very, very expensive. So every day there's an ethical dilemma. Who should be in intensive care or high dependency unit? Who should stay in because another person's coming in? Can you predict the outcome? So vegetative state there isn't a legal definition. There are guidelines about it. But it says it's an individual who is not aware of their environment, no higher cognitive function, but might, and that's important, can inconsistently respond to stimuli. And it's known that this is very hard to diagnose. It's extremely vague. And Andrews in '96 actually did a very big study of large numbers of people in vegetative state and shown that it was misdiagnosed 43% of the time. So this is a big problem. There's another condition which is related. It's called a minimal conscious state. It's a little bit easier to define. It's a condition of severely altered consciousness, which is about being aware of the environment, in which minimal but definite behavioural evidence of self or environmental awareness is demonstrated. They do respond to some stimuli. So I'm not going to go into the details of how you assess people who are unconscious. There are a whole set of different tools, coma scales and so on to do this. But almost all of the ways of assessing conscious state and degrees of being in a coma depend on the person being able to make a response, some kind of meaningful behavioural response. And of course, if they can't make that behavioural response, then it's extremely hard to do these assessments. And I'll give you an example of what happens. So a famous study not that long ago by a person called Loris, used high-intensity electrical stimulation and demonstrated activation in a selection of areas in these people unconscious. I mean, this is painful stimuli are being given to people in an unconscious state, and I'll come back to that. Whereas another study showed actually other areas are active. So, what's going on? So in 2006, some people in Cambridge, Adrian Owen and colleagues, used an MRI scanner, one of these things you put your head in, non-invasive, and they just measured blood flow. And the brain, just like your muscles, if you exercise your muscles, your brain, when it's active in a particular area, it becomes metabolically active, it needs more blood flow. So by monitoring the blood flow, you can use that as a proxy of which parts of the brain are active. And what they did is they spoke to people who were in a vegetative state, just spoke to them, explained what they were going to do, and they said, what we want you to do is imagine a particular action or another action. And what he actually showed was in a number of these individuals, they retained a level of awareness that was not apparent from the lack of behaviour. In other words, by reading out from the brain, they were able to see when they were imagining doing one action or another. So these people are unable to make a behavioural response, but they are able to respond in terms of action. So what does that mean about using painful stimuli with unconscious people? It caused a storm. Activation alone does not imply awareness. A man called Roper called this shadows on a wall. It's this, you're just not actually looking at what the brain is doing. It's not about consciousness, it's things that are unrelated to it. Then in 2010, Monty showed a different thing. What they do is 54 patients now, not a small number, 23 in a vegetative state, 31 with this minimal conscious state. And what they showed, they didn't show in everyone, but 5 of them were able to modulate their activity in a scanner. So they're able to lie in a scanner and they're able to answer questions by doing particular things that change the blood flow in particular brain areas. And what they had to do was imagine either playing tennis or they had to imagine walking around a room. And on the basis of that, these people were able to, from their so-called minimal conscious or vegetative state, were able to answer yes or no. They were able to give responses by modulating their brain activity. So reading the brain, therefore, is of use because you can actually do things by informed consent. You're starting possibly to be able to help them make decisions about it in those situations. In fact, 2, because this was discovered, 2 later went on to show actual behavioural evidence because they asked the right questions and they asked questions in a particular way. So it has a clinical use. But now people have gone a bit further, and I'm getting on to the third bit about where it's going. Am I okay? When did you have that thought, and what was it? I've already mentioned that you can read out from the brain about what you were seeing, but let's go a little bit deeper. A group in Berlin, again using these non-invasive techniques, were able to look at the whole brain, and they recorded activity when you were being asked to make what you thought was spontaneous decisions. So all you had to do was make a prediction of flipping a coin. It's very, very simple. They've done other things since then, and you had to predict what was going on. And they got the people to make this, to say when they thought they were consciously aware of what they were going to say, and they looked at the brain activity. What they showed was 6 to 8 seconds before you actually made the decision, the frontal areas were already totally committed to what the decision was going to be, long before you were consciously aware of it. Now, the frontal areas are very, very complicated, and there's all sorts of things going on, we can talk about it, but what you were going to decide is done a long time before in those experiments, before you actually are consciously aware, oh, I'm going to choose heads, or I'm going to choose tails. So where next? Well, in Science in 2008, there was an article predicting human brain activity associated with the meaning of nouns. And so what's already happened, in fact, it's come out just recently now from reading. People are able to predict what you're reading, but not just say it's like a visual image, like I said before, about what's going on in this room and predicting what you were imagining, for example, in a dream. They're actually predicting what you meant, what meaning you got from those nouns, because they can be in different contexts and you get a very different meaning. More controversially, Journal of Neuroscience, and the neuroscience people here will think this is a fairly reputable journal, published a paper called Neural Responses to Unattended Products Predict Later Consumer Choices. And this has led to the whole area called neuroeconomics. So companies are now trying to work out, as you walk round a supermarket, where should the product placement be? How should the product placement be done so that your subconscious recognises that and it predicts your consumer choices? They're doing this with non-invasive imaging devices. Another fairly famous, pretty hardcore science journal, Journal of Biophysics, quite a long time ago, 2005, detecting deception using MRI. So they got people to simulate creating a crime. No one had actually created the crime, so they had to pretend that they were lying about something, but they were still able to do it. Now, I haven't gone through any of the evidence. I hope this will come up in the discussion, the debate. What is the statistics of this? What's the probability? But I can tell you that in India now, based on non-invasive imaging, this is now allowed in courts. So they put people in a scanner, different types of scanners, and they work out from that, they think, whether or not you were at the scene of the crime, whether or not your brain is able to recall and show that you were there or not. And so to give another quote, in USA Today, there will be a Supreme Court case about this, and you can almost imagine them cheering about the money that would be found. And that was the director of the Center of Ethics in Atlanta. So I'm going to finish. I'm going to finish with a quote from Barbara Sakian, and this at the University of Cambridge. So the Nuffield Centre for Bioethics have had two really big workshops on this, and still debating about how this should be presented to the government in terms of ethical debate. And one of them was about these emerging neurotechnologies. What are the ethical implications of them? Barbara was one of the people who gave evidence of this, and to quote what she said was, a lot of neuroscientists in the field are very cautious and say we can't talk about reading the individual's mind. Now, I've tried not to use the word mind up until that. That's what she said, about reading the individual's mind, and right now that's very true. This was a few years ago. But we're moving ahead so rapidly, it's not going to be that long before we were able to tell whether someone's making up a story or whether someone intended to do a crime with a certain degree of certainty. And so that, of course, is what gives rise to The Guardian and all the newspaper headlines and the thing that I sent around. And if you read the last paragraph of the thing I sent around, I don't know where it's gone. Just pass it back, I'll just read it out. So one of the things it says, so the paragraph but one, it's about neuroprattle that locates our experiences, propensities and character and activities of our brain. Stop us really thinking about this properly, like Gilbert Ryle did in The Concept of Mind quite some time ago. And it says, next time you see a pretty coloured brain scan, I wasn't allowed to show any pretty coloured brain scans, next to an article burbling on about breakthroughs in understanding of our humanity, reach for the salt. So, and in here there are some nice quotes like, MRI, this non-invasive device, well, Matt Crawford says, and that's not the Archers, Matt Crawford, it's a different person, said, it's a fast, MRI, it's a fast-acting solvent of the critical faculties. So I hope we'll stop there and see whether we can have a debate about whether it is or isn't.
Cafe Culture North East is supported by Newcastle University, Peels and the British Science Association. We're also supported by Ginger's Cafe in Dance City, who host the events.